Okay, so you guys have met our two guests here, our two ambassadors, Dr. Woodworth and Dr. Dezfoli. Brian deGuzman is on the far right there. He's my longtime colleague. He was a co-founder with me of PAVmed, also a cardiothoracic surgeon. And so we are going to talk about, really maybe try to flesh out some of the incredible anecdotes and insights that you guys provided us. And I thought I would start with a question for all three of you, which I think Dr. Dezfoli sort of really spent a fair amount of time on this, which is that we've had guidelines, now I think we're at 15 years or so since the first BE screening guidelines came out, something in that range. We know who this population is, we know exactly what we need to do. I think you did a great job of emphasizing that. So maybe you could just flesh out a little bit more about how you see the landscape from this period of 10 or 15 years where we kind of knew what we needed to do, but it wasn't getting done, to rapidly moving into a situation that's more akin to what we see in other cancers and utilizing this technology appropriately. Why don't you go ahead and start?
Hello. Okay.
Yeah.
So I think the statistics really speak for themselves. We've understood what causes Barrett's esophagus. We know that Barrett's esophagus, what the pathogenesis is towards esophagus cancer, and yet, as you saw the statistics that we presented, the rise of esophagus cancer over the last multiple decades. So obviously we're missing something here, so it all goes down to those risk factors. I think one of the issues in the past has been that clinicians really get hung up on acid reflux, and it being this prerequisite risk factor for Barrett's esophagus. So we've been dismissing all the patients who don't really have symptomatic acid reflux and really missing them. As you saw from the case I presented, the patient didn't really qualify for having acid reflux as a diagnosis, and so that's a patient who potentially would have been dismissed had we thought about him of thinking of acid reflux as a prerequisite one. So I think in the coming years, we really have to pay attention to these new guidelines, especially the ones that have been set forth by the AGA, and also recognize that there are other risk factors. Now, some of those risk factors are those that give you risk for acid reflux, such as obesity, things like that. But if we start, removing that as a prerequisite, I think we're going to approach this better and capture more patients. I think we also have to consider the fact that I was talking to Sean about this earlier, we have really great medications on the market right now. A lot of patients are self-treating themselves for acid reflux, so they don't really know to even express that concern to their doctors. So it's up to us as clinicians to look at their medication history, to really extract that information from the patient. So I think to answer your question, I think what we really need to start doing is, as clinicians, the onus is really now on us to kind of, first of all, change the paradigm as to how we're approaching risk factors for Barrett's, but also understand how to extract information we need to understand where those risk factors are and if our patient is at risk. And once we understand that is only when we can start really ramping up the testing and getting these patients identified. Yeah,
it's great that we have such a good partnership with the GI and the foregut surgery community, because that's not always the case. Or a lot of times a new technology is coming in to supplant a technology that's sort of a bread and butter test. I mean, I think my understanding is that Cologuard, had to sort of effectively do an end around most gastroenterologists during their period of ramp up. And it's just much nicer that we have the ability to have a partnership. So maybe, I don't know if you'd like to elaborate a little bit on that and how it relates to sort of the changing landscape for BE screening.
Yeah. So what I think is really interesting is that Lucid and EsoCheck and EsoGuard are providing something that hasn't been available before, and that's access to the healthcare system. So previously, a patient was required to get any sort of cancer screening by going and seeing an interventional gastroenterologist, or when I use the word interventional, I mean have a procedure that actually requires the patient to get anesthesia and then be tested in that manner. This really opens up the opportunity for patients to go get evaluated at a much earlier stage, and therefore, or thereby, allow them to receive a more accurate diagnosis. So if I show up and I say, look, I've got symptoms, I'm concerned, I've got family history, whatever the reason, and I can have an EsoCheck done and then run the EsoGuard, I can find out if I need to undergo further screening. So now I can isolate my opportunity to receive directed care and move myself into more of a diagnostic role, and then enter myself into a healthcare system that is flush with new technologies that are doing nothing but to improve things. So once I have my diagnostic endoscopy and I get a biopsy and it's positive for Barrett's, now I can get a 5-year predictive value for progression with Castle Biosciences Tissue Cipher. So Lucid fits into this chain. And then once you've decided to have surgery, you can go enter in, and like the Lynx procedure from Johnson & Johnson that I had, it's all building this palette of colors that are creating a rainbow for an opportunity for patients to get care earlier, and thereby break the pattern that we've been in, break the mold where we haven't been successful with what we're doing because we're losing, and enter a phase where we're actually having a positive impact like we saw with breast cancer starting in the late 1980s.
That's great. I have a follow-up for you, Brian, later, but I want actually, you guys remind me of one thing that's not on my list that I wanted to ask you about, which is the capacity of esophagologists, right? Foregut specialists. You know, we have, I believe it's 10, 15,000 GIs in this country, but a small fraction of them and surgeons actually have expertise and interest and capacity to handle esophageal disease. And I've heard it come up several times that even if we had the sort of the impetus to do as many screening endoscopies as we could, that there just isn't the capacity to do that. So maybe you might talk a little bit about how that folds into how having a non-invasive test can help address this effectively, you know, workforce shortage in doing that, if you agree with that.
Yeah, certainly. I mean, right now I'm looking at my own practice, and I'm already right now trying to recruit another part-time physician, just to, not even to see new patients for me, but just to scope patients that are on my own backlog. Right. So that exemplifies, you know, the time. We don't have enough hours in the day to try to take care of all of these patients and then balance our, you know, our families and et cetera. So yeah, I think that EsoGuard perfectly fits into that. So right now, when I see patients, I'm very careful as to how to risk stratify them and think of their pretest probability. And I'm very quick to give them an EsoGuard if I think that they're on the border of risk. They're at risk, but they're at the border. So they don't necessarily have to get an endoscopy. And if they do, they're going to be waiting 2, 3, 4 months. So EsoGuard is a perfect solution for that, at least when it comes to my practice.
Yes.
Taking the opportunity to allow physicians and healthcare workers to operate at their peak level, at the area that they have the most knowledge, is ideal, especially in an environment where there's limited access to experts such as Seper here. So if I can isolate those individuals at highest risk for having a precancerous condition and funnel those patients to Seper and his colleagues, then I'm going to get a higher return on my investment. Whereas right now we're just taking, you're over 50, you've got time, we'll go ahead and do that endoscopy. Let's let a nurse practitioner or another mid-level run the test, do the assessments, and then keep Seper where he needs to be, which is in the endoscopy lab, or myself in the operating room, performing what we know how to do that others don't know how to do.
And just to piggyback off of that, one strategy we have in my office is that I get patients who are being booked directly for colonoscopy. These are patients who are low risk and otherwise don't really need to have a face-to-face meeting with me prior to them getting their average risk colon cancer screening. So what we do in my office is that my staff is trained to look at those patients' demographics, especially their gender, their race, their weight, et cetera. If they identify them as having 3 or more risk factors for Barrett's, they call the patient, they book them for an EsoGuard prior to me getting the colonoscopy done. If that EsoGuard is positive, they then convert that colonoscopy to an endoscopy colonoscopy. So what this does for my capacity and for my efficiency is that it decreases that extra step of them having to come and see me, because that's information that if I were to take time out of my schedule to do a consultation, it's easy demographic information that I would be doing no different than my medical assistant who can just do it on the phone. And so it spares the patient of having to come in, take a day off of work. It spares me of having to clog up my clinic schedule. They can just go directly to the procedure, and I can get it done if it's positive.
It's a great anecdote, and you just remind me one other thing, which is that, the train of thought here, which is that I think you described an experience that we expect, which is that because the positive predictive value of our test is higher than the 7 to 10% kind of baseline rate that you'd expect in screening endoscopy, that your yield from your endoscopies are going to be higher. So you said you're doing more endoscopies, yeah, and presumably a higher percentage of them end up going down the path. You end up finding Barrett's, and they end up going for surveillance. Is that?
Yeah. Oh yeah. So my volume, I'm already trying to think about the future now. In the next, as I develop and evolve my practice, so more and more patients that that are having positive EsoGuards, that then not only in the short term does that add to my practice and my volume because they get an automatic endoscopy, but as you mentioned, if they have a positive biopsy, then that's a lifelong patient now. And so that's a patient who is going to routinely see me in the clinic, so I can make sure that they're on the medication that's supposed to prevent them from progressing to dysplasia. It's called chemoprevention. And then they're also going to get surveillance endoscopies. Because of that, what I was saying earlier about that special bond that we get with the patient, because the patient sees that I don't want to say thinking outside the box. I don't really consider this outside the box. I'm just, thinking about more advanced modern medicine. They really, it strengthens the bond that I have with them. So my patients that I've seen 5 years ago have stuck with me. So I anticipate that that's going to stay going forward. So my business and my practice is just going to get larger and larger.
And there's one other element of that, which is it's great for you and your practice and your colleagues. That's great. We like that. It's great for the patients, because if you can have a patient who goes into an endoscopy with a 30% chance of having a positive versus 7, that's great as well. But it is also, I sort of hinted at this earlier, there's a clinical utility aspect of this. So showing that our test yields higher, generates higher yields from endoscopies and more positives from endoscopy is generally considered another sort of measure of clinical utility. That happens in other areas as well. So that's we think that's going to be helpful for them as well.
Definitely. I'm looking at my data right now, and I'm seeing that we are correctly selecting the patients based on the results that we're getting. We're correctly identifying the patients and getting the expected numbers that we should.
Brian, maybe you could, you spent a lot of time on the road and helping with peer-to-peer and engaging an even broader population of primary care physicians and GIs, foregut surgeons, and so forth. Maybe give the audience a bit of a flavor of some of the dynamics. And we've obviously have 2 superstars here who are passionate ambassadors for what we're doing, but I think our sense is that the broader community is also embracing this quite well.
Yeah, I mean, you guys have heard this story. I think maybe some of you from a scientific and from a clinical perspective for the first time, but it's a compelling story. Yeah. And I grew up in a surgeon's household. My father was a thoracic surgeon. He did thousands of esophagectomies. Lishan and I did probably hundreds of them in training. And I think one of the things I just wanted to get out there that I don't think either of you guys touched on is those patients not only have a very poor survival, but those operations are incredibly difficult. They're fraught with complications, and they are just not a rosy picture of medical care. So anything we can do to avoid that is really kind of a life-changing thing for the patients, but also for us as providers. For me and Lishan to formerly have been cardiac surgeons where we could do 2 operations a day, now we're doing thousands of tests and potentially saving thousands of lives every year is absolutely incredible for us as practitioners. But the story that we have here is a test that is incredibly accurate. It's incredibly robust. It's a patient population that is currently not being screened, that can have a tremendous impact on thousands and thousands of lives. The delta between a patient with Barrett's esophagus with dysplasia with a 90% chance of cure from a very simple procedure versus the 21,000 patients a year that the second that you transform from dysplastic to cancer with almost a certain death rate is a huge delta. And when you talk about this very simple concept and the very simple test that's easy to do, some of you have probably undergone the test. I've done it dozens of times in demonstrations. It's very simple. When you talk about those elements with primary care providers, nurse practitioners, the nurse practitioner that took care of the San Antonio firefighters, that's how the whole firefighter and check your food tube process got started. It's a very compelling story, and it's very easy to understand. It's very relatable, and everybody has these patients. There are so many patients that all of these providers see every day in their practices. I just recently gave a talk at a nurse practitioners meeting, a national meeting for continuing education within the nurse practitioner societies. And after the talk, I had at least 10 nurse practitioners approach me afterwards. I have a patient, I have a family member, I have somebody that needs to be screened that this would be perfect for. So, and so far there are, I looked at the list yesterday of all the providers around the country, individual providers that have ordered the test. It's more than 800 providers now. Yeah. So it's an incredibly compelling test. It's an incredibly compelling story, and there's just not a way, at least from a clinical perspective, to say, oh, I don't really want to do that. It's really just comes down to how we can effectively get it into their workflow, how can we assist them in facilitating use in their practices. So, you know, the easier answer is it's easy to talk to them, and it's very simple to create champions similar to these guys.
I wanted to add on to that. The implications are profound. I hate to keep going back to that same story, but the case, if you think about it, that as a physician, as a clinician, we are obligated to prevent disease if we have the tools to do so. Our patients are ignorant to that many of the times. It's our obligation to educate them and inform them that they have a risk for something and there is a tool available. So I agree with you. We are obligated to use the test if we identify the patient as having risk. In that case presentation I gave you, I did a colonoscopy on that individual. I probably removed a few polyps. So you can say that we prevented him from getting colon cancer. Yet, had he not been diagnosed with Barrett's appropriately, he could have easily just shown up at my door 10 years from now with esophagus cancer. So that would have defeated the purpose, right? So I'm preventing colon cancer, but meanwhile, he has a silent disease that's going to kill him anyways. So I felt a sense of obligation to do the EsoGuard on him because we now have the tool. 3-4 years ago, I wouldn't have had the tool, and we just had to accept that, just like how we have to accept it currently for pancreatic cancer, liver cancer, and hopefully the paradigm shifts when it comes to those as well. But as long as I have the tool and the patient has risk, I'm obligated to do it.
Yeah. Okay, we're going to wrap up. We have 2 more things, but I wanted to point out, Anthony, you had mentioned, I think, about what are the obstacles for primary care physicians and so forth to get. And I think at the beginning, I think on my checklist, I sort of pointed out that we don't have obstacles anymore. We've actually figured it out. We can go to physicians. GIs are not threatened. Surgeons will engage with us, and as Brian mentioned, we go to meetings where there are hundreds of nurse practitioners or other primary care physicians, and it's just not an obstacle. It's just right now we're just trying to keep things at a steady pace so that we can start getting some wins on the reimbursement side, and then when we do decide to put our foot in the pedal, we don't feel we're going to have any meaningful obstacles with regard to physician adoption. I just wanted to point that out. So I have 2 quick things. One of them. I was wondering if you could, I don't want to be morbid, okay, but I would like to sort of build a little bit on what Brian had started on, Phillip, because, all cancer is bad. We don't want to get into sort of like, which is, you get, breast cancer is terrible, you have to go chemo and sometimes radiation, and there's all sorts of complications associated with that. Colectomies, they're all bad, okay? But I would like to give the audience a bit of a flavor, again, with maybe with the risk of being a bit morbid, of sort of following up a little bit on what Brian said. You do esophagectomies with a robot, but still, these patients are getting chemo, they're getting radiation, they have leaks, they end up back in the hospital and so forth. And so the experience of 80% of these people who die within the first 5 years, even the ones who survive out to 5 years, the suffering that we're seeking to mitigate here is profound, and you have a front row seat to that. So I thought maybe you could give a little bit of a flavor of that with that.
Well, so what we're trying to prevent is death. And then we're trying to prevent esophagectomy. And removing an esophagus is not an easy thing. It's not like going in and having a hernia repair or even a breast biopsy where you remove a section of the breast. You readjust the anatomy, and so now you have no protection against any sort of reflux. You take out the esophagus, you create a tube either from the stomach or from the colon, you bring it up, perform an anastomosis somewhere up higher in the chest or the neck. So your life is forever altered. You become absolutely cognizant to how you eat, when you eat, and what you eat, because you are not a regular person anymore. So your existence has been changed. I think the morbidity of the operations and of course esophageal cancer itself are profound. But you touched on something that I think is even more profound that Lucid and EsoGuard offer the patients, and it's an opportunity to exit a state of ignorance. You're going to now be able to empower a patient with the knowledge of their condition and their status. One of the things that I was talking to some people earlier that I found most profound when I started really re-examining how we discussed Barrett's esophagus, a precancerous condition, is once you identify somebody with a precancerous state, their mental perception of what's going on around them in the world changes. And I think it's only fair as clinicians that we offer people true assessments of their life and what's going on. And never before have we had something that's so novel, so simple, and so widely accessible as this test that could profoundly prevent a death, morbid operation, or the distress of everyday reflux that I've experienced daily.
You're such an upbeat guy. You were able to tell that without a hint of being morbid. So thanks. And Sean's giving me the wrap it up, but I'm going to do one more to Sep, Dr. Dezfoli here. You know, I don't think we spent enough time talking about the fact. So look, we said we have a great test. We can pick up this precancerous condition. We can do surveillance on those who have the earlier non-dysplastic earlier Barrett's, but an extremely important part of why this has the ability to be a successful early detection program has to do with the fact that we can treat dysplasia with a very effective ablation procedure endoscopically, with the opportunity to cure these patients, not just of the dysplastic disease, but of the underlying Barrett's altogether. So if that part did not exist, then the whole this would be a bit of a house of cards. The whole thing would collapse. You know, picking up something early, we know this in other situations, picking up a cancer early, even in precancer stage, doesn't necessarily change outcomes unless you can intervene at some point in time and basically direct the pathway in another direction. So I don't think we gave enough credit and enough insight into how powerful an endoscopic ablation procedure is in sort of closing the loop on a successful, making this a successful early detection program. So maybe you could just flesh that out a little bit as we close.
Yeah, so if you remember the slide that had the three layers of progression towards esophagus cancer, I can confidently say that as long as a patient is identified at any of the two middle ones, that being Barrett's without dysplasia or Barrett's with dysplasia, I can confidently say that a majority, if not all of those patients can be prevented to move on to esophagus cancer with the tools and the medications that we have. So if they have Barrett's without dysplasia, the standard of care would be to put them on medication and to do surveillance programs with endoscopy, as I mentioned earlier. And then for patients, to your point, who actually do develop dysplasia, those patients are referred. They go to interventional gastroenterologists and they do ablation therapies, resections called EMR. They have multiple tools that work very effectively. Yep. So even though they move into an even higher risk, they can still be stopped. And so, yes, I think that, yep, again, it just drives the point home is prevention, and identifying them prior to them getting esophagus cancer.
So the patient you showed had non-dysplastic, so
Yeah,
they ended up in a surveillance. The patient that Sean talked about from Idaho had high-grade dysplasia, so like one little final step before going to esophageal cancer. The guy who saw his allergist and checked the box on the sheet, that guy was found to have high-grade dysplasia. So he was literally like one step away from having this terrible disease.
Very high risk.
And he ended up going to Utah to get ablation. I think it took 4 or 5 sessions to do so. And they went in and basically used a Medtronic Barrett's device, I assume, to destroy the abnormal cells. And he'll need some monitoring, but we can consider him cured,
yeah,
and that we've eliminated his risk of cancer.
And if you think about that case, had EsoGuard been available probably, I would say, 7 or 8 years ago, one can argue that if he had gotten the EsoGuard 7 or 8 years ago, he probably would have been caught prior to him developing dysplasia, and he would not have had to go through even more invasive procedures. Luckily, we caught this patient that Sean spoke about prior to him getting esophagus cancer, but this is the step now. Yeah. So there are patients who are living now without dysplasia, and we can catch them now and not let them even get to that stage where they have to go get more procedures, invasive procedures, and such high, intense surveillance.